Welcome to Leaders Abstract, the podcast about the inner work of leadership. Here we explore the ideas, habits, and blind spots that shape how mission-driven leaders show up for their teams and the communities they serve. I'm your host, Dr. Jeremy Rutter, and with me, of course, is my intrepid co-host, Mr. Joe Tomaino. Joe, how are you?
I'm doing well, Jeremy. It's good to be on.
It's good to see you. And if you've noticed, your name's on the logo now.
I know. I've made it. I've made the lower billing.
That's the lower billing. We'll switch it up every once in a while.
Oh, that's quite all right. You're the founder.
That's good. And coffee cups are on the way.
Yeah, right now I have my Italian American retrieving team mug, but soon to be replaced.
That's good. Very good. Joe, we have a guest today. I'd like to turn it over to you to introduce our guest.
Sure. So our guest is someone I've worked with in the industry since the 1990s, Brad Markowitz. Brad has had a number of interesting positions in healthcare organizations, which I'll let him speak to, both as a provider, as a technology company founder, as a board member of a not-for-profit skilled nursing facility. So, Brad, why don't you go ahead and give us a little bit of some insight into all those different roles and how it shapes the person you are today.
Thanks, Joan. Thanks, Jeremy. So glad to be here. So yes, I got involved in healthcare, sort of a left-hand turn in my career. Originally have a finance background, all the way back in 1994 when I was approached by two physicians who were the medical directors in a total of 8 nursing homes in New York City. Did a little bit of consulting for them, and before I knew it, we had created what became the second largest provider of medical services in nursing homes in the United States. That company had 250 providers in 80 facilities across New York, Connecticut, and Massachusetts. That entity then became a game of Pac-Man. That entity became part of the only entity that was larger than us, IPC, the hospitalist company, which then became part of what was then the largest provider of physician services in the country, the largest employer of physicians, Team Health. And I stayed with that organization all the way through. At the end, I was running the nation's largest provider of medical services and long-term care facilities. We had 1,600 physicians and nurse practitioners in over 2,000 nursing homes across the country. And along the way, I've done a variety of other things, was one of the founders of what became the leading EMR for physicians in nursing homes, Charimed, became the founder of another technology company that was acquired by PCC and integrated into their offerings to skilled nursing facilities. I left Team Health in 2019, started 2 other practice groups, one in North Carolina, one in upstate New York. Both of those were merged into Curana in December of 2025, which is why I have the time to chat with these 2 nice gentlemen.
Hey, Brad, what was the application that got absorbed by PCC? That's interesting.
So the name of the company was Patient Pattern, and as these things go, it started out with one thesis, which really, if that had been what the company became, it would have been overtaken by AI. The concept was that the long-term care environment, the nursing home environment in particular, is so rich in data that when a physician or a nurse practitioner walks through the front door, of course, they're dealing with regulatory visits, they're dealing with requests by the nursing staff, but a computer should be able to tap the clinician on the shoulder and say, nobody in the building realizes it, but Mr. Markowitz in room 305, he has a statistically significant increased risk of being hospitalized in the next 2 weeks. Based on the data that we have on this patient, you ought to go and see him and see if there's some reason to intervene in the trajectory of his care. So, Of course, that was the thesis. It was a great idea. What wound up being interesting to PCC, however, was that the company became a software platform that solved for iSNPs that are owned by providers, solved a problem where there were 5 or 6 different pieces of software they were all using and it was driving them crazy. They wanted a single unified platform. So, great idea in theory. That's what attracted me. Wound
Yeah.
up being a commercial success for a different reason, and interesting to PCC for that alternate reason. But,
Interesting.
lot of twists and turns along the way. But the thesis behind these two groups that we started in 2021 and merged into Curana, which is now the largest provider of medical care and nursing homes in the United States. They're all in on what has become my deep conviction, that value-based care is what is the future for skilled nursing facilities in the United States. And we built two groups that were very high performers on all the relevant metrics: hospitalization, rehospitalization, unnecessary ER visits, polypharmacy, all the key elements that we all know are first and foremost quality indicators. But now there are reimbursement methodologies for physician groups, and it's starting to happen now for nursing homes, where you get paid based on the care you deliver, not just heads and beds.
Interesting.
Yeah, that's outstanding. Expand on that, Brad. I'm interested in how that's going to really change not only nursing home reimbursement, but some of the leadership that we're going to need within nursing homes, including our board, our medical directors, and administrators. How's that going to
Yeah.
change?
Well, it's going to change it dramatically, in my opinion. So, look, it's running a nursing home, not for profit or for profit, is a brutal thing these days. We all know that reimbursement does not keep up with costs. Mandates from the government, which are, we're all in favor of. We're all in favor of more nursing hours. We're all in favor of improving care, but the money has to come from somewhere. And it's not coming from Medicare or Medicaid rates. Certainly not Medicaid, but even Medicare is not keeping up with what's required. So there now are programs, primarily Medicare and Medicaid, but increasingly the commercial payers will drop in behind. It always works that way. They'll follow the path that's blazed by Medicare. There are programs that are meaningful in terms of the additional payments that are available to providers. The attribution right now is coming through physician groups. So the way that Medicare, whether it started with I-SNPs, but it's really the ACOs where there's real money here on the table. It comes through the physician group, but of course, at the end of the day, the facility has some control over who's in their building, right? And the I-SNPs have been gain sharing with facilities, but the real opportunity is with ACOs. And you have to change the trajectory of patient care. You have to change the way that care is being delivered. And in the end, the only ones who can truly impact that in a significant way are your medical staff, right? So the classic example, and I'll give you an actual example. This is not a made up theoretical example. This happened in one of the nursing homes in North Carolina. It's a Sunday afternoon, and the only nurse in the building, these are smaller nursing homes, typically 80, 90, 100 beds, so not all that different from much of upstate New York. The sole nurse in that nursing home on a Sunday afternoon calls and wants to transfer the patient out. That wasn't a request. That was instructions to the medical provider, right? And you can argue with that nurse all you want, but the truth is the patient needs to go out because they don't have the resources in the building on Sunday afternoon to do what's necessary for the patient, right? Okay, fine. Patient gets transferred out on Sunday afternoon. But because our physician medical director in that building had made an effort to build a relationship with the physician director of the ER in the local hospital and with the head of the hospitalist program, very simple. Monday morning, he'd get a list of who was transferred over the weekend. He'd, as a routine matter, give a call first thing in the morning before he left his house and say, hey, I see I've got 2 patients from this nursing home and 1 patient from that nursing home that got transferred in over the weekend. Let's have a conversation. And physician to physician, they would decide who could come back to the nursing home on Monday morning. So those admissions become obs stays. It saves the payer money, but more importantly, it's better care, right? I
And it
mean,
keeps the census up.
well,
Love
it
it.
does. It's
Yeah.
good. It's good for the facility financially in that regard, for
Yeah.
sure, right? I mean, no more bed hold; those days are long gone.
Right.
But start with it's better for the patient, right? The patient's in the hospital for 24 hours, but gets back to the nursing home where the staff knows the patient. That I mean, your audience all know better than
Okay.
I all
Okay.
the
So
reasons
Brad,
why.
I'm the nurse. Okay. So yeah, we know it's going to be better for the patient, but I'm interested in the money. Can can you tell me how this
Yeah.
works? Like you've thrown around some things like ACO and physicians and
Sure.
iSNPs and but a lot of our audience might not be familiar with all these things. So like, and yeah, we agree the bottom line is it's better patient care, but we're also kind of interested in how we generate some additional revenue through that.
Right. So really quite simple. If the nursing home has a contractual arrangement with the ACO, then the ACO can share dollars back with the nursing home. And as you said, just putting it very black and white, how do the dollars flow? Well, the nursing home controls access to the patients. The doctors are the ones who can change the key costs that uh, flip that patient from being a small loss or a small gain just by accident, which is what tends to happen, to being a significant savings, because the key issue is avoidable hospitalizations,
Right.
right?
Right.
The polypharmacy, there's some other things around the edges, but the key thing is treating in place in the nursing home, taking that Sunday transfer to the hospital, turning that into an OB stay. So it costs the system $3,000 instead of $18,000, let's say, on a Tuesday afternoon, having everybody lean into treating the patient in place. And the ACOs have a lot of flexibility how they pay the facility. They could pay you for starting an IV on site, for example, instead of transferring to the hospital. But the key thing is they can pay you a monthly per diem, and they will. This is what's starting to happen. Pay a monthly per diem for every patient that's enrolled in the program. And more importantly, the larger number is a share of the savings. So
Yeah.
uh,
Yeah.
the programs are changing now, right? Um, but in 2024, which is the last year for which we have full results, I've seen savings per patient be as much as $18,000, and nursing homes being paid as much as a 25% share. Single site nursing homes, nobody using their leverage because
Yeah.
they have a large network. So 25% of 18,000 times the Medicare fee-for-service patients in your building comes out to real money.
Sure
Wow.
does.
Yeah.
Like,
And I presume since this is a CMS program, you have to be at least a 3-star facility to contract with the ACO, or is that no longer the case?
To my knowledge, that is not the case right now. That's the case with an iSNP, but the ACO programs are actually, the ones I'm talking about are actually under CMMI and
Oh,
don't
yeah.
have, so they don't have the permanent designation, therefore don't follow some of the rules that apply to Medicare Advantage programs otherwise, that 3-star rule,
Do
right?
they still get waivers to like the?
They can do whatever they decide to do in conjunction with a nursing home. They can contract to waive the 3 days. They can contract to provide you with additional payments for certain care that would avoid a hospital transfer. What I have seen emerging is the concept of a modest monthly stipend, which goes either to the physician group or to the nursing home, some combination thereof. But the real money is getting a share of the savings. And I've seen nursing homes not uncommonly getting 25% and the physician group getting an additional 25%. Now, that assumes that it's an organized physician group that is devoting real resources to care management. If you're a nursing home where you've got a couple of community providers and they're not terribly engaged, you can still do this, but there's no reason for the physicians in that case to be getting a share of the savings. You just need to have your medical director work with you so that the ACO gets the attribution they need. Attribution comes from the preponderance of the primary care visits. So if someone is a long-term care resident in a nursing home, we know who that person's going to be. It's going to be the physician or the nurse practitioner who you have in your building.
That's right. And Brad, you touched on it earlier in your example there about how the nurse calls up the physician or the on-call physician and essentially says they got to go. If we're to move towards value-based care, what kind of training and resources do we need to give to our frontline staff in order to make sure that that isn't the first knee-jerk reaction, which is send them out?
Yeah. Well, look, there's no magic to this. Being able to do IV hydration in a building, for example, is one thing that would sort of be a must, right? It's always the case that ongoing training of your nursing staff, having them be able to deal with more clinically complex patients is a good thing, right? I think every nursing home is trying to take more clinically complex patients for short stays, Medicare stays, right? Other than IV hydration, which some nursing homes don't do for cost or training reasons, you know, the complexity of the care you're rendering to long-term care patients is not the same as your short-term patients. It's not going to primarily be a training issue with your nursing staff. It's a staffing question, right? That nursing home on a Sunday afternoon who has one nurse in the building for 80 or 90 patients, it's just not realistic, perhaps, to keep a patient in the building on that weekend day or overnight. I'm being very pragmatic about it, right?
Yeah.
You've got
Absolutely.
one nurse in the building. You need to turf that patient to a hospital so you can take care of all the other patients in the facility safely. But then the next morning, the next weekday morning, when you have your day staff and you have more than one nurse and the doctor can come in or the NP can come in and you can actually do a medical plan of care, just bring them back in. That's an example of a creative way to break the cycle that costs the system so much money unnecessarily, right? I mean, nursing homes are capable of providing a lot of the care that is provided in hospitals for our long-term residents. It's
That's
cost
right.
shifting. It's the insanity of our healthcare reimbursement system that causes patients to go out.
We saw that during COVID, where when they got rid of the 3-day stay requirement and you could treat in place for a lot of people. And I saw I had switched organizations halfway through COVID, so I had one organization on one side of the switch. I won't say which one is which, but on one side of the switch, they had a really great contract with their iSNP, and the other side of the organization during the switch did not have a great contract with their iSNP. And even though they were skilling and treating in place, they're just still getting their daily per diem. Whereas we could have billed out, Medicare for those, you have someone who contracts COVID and then you're able to waive the 3-day stay and you treat in place and you're able to bill like a post-acute rehab stay through your iSNP. But a lot of that runs down to contracting and making sure that you're looking at your contracts in a fashion that is beneficial for your own organization. Joe, did you experience that in some of your clients as well? They kind of got how do I put this nicely? Screwed over by
Yeah.
the in COVID.
Yeah. Yep. But this whole topic reminds me, I was CEO of 3 nursing homes. And I mean, you guys all look like, you're my contemporaries. Remember in kindergarten when we'd wait for the school bus, they made these little construction paper things with the school bus and had your name and your homeroom on it. So
Yeah, absolutely.
when you get off the bus, you'd know where to go. So I had our activities
I
department.
walked to school, Joe. I walked.
Oh, okay.
Both
So
ways.
you
Uphill
were
both ways in the
That's right.
snow,
It was
barefoot.
upstate New York.
okay. Well,
Yes.
just bear with me with this story, right?
Okay, let's hear it.
So I had the activities department in my 3 nursing homes doing activities with the residents where they did a construction paper ambulance, right? And it said they wrote on the ambulance, "Don't even think about admitting me without calling my doctor," and it was the cell phone number of the doctor. and they put that in the overbed table. And whenever someone would be sent out to the hospital, they would pin that to the outside of their gown.
I know who was. I know who you were not. Who was not your fan, Joe.
Yeah,
Uh,
exactly.
That might,
Well, you know, because the hospitals, you know, so one of the nursing homes was on the balance sheet of the hospital, right? We were, you know, corporately integrated, and I'd go over to the, you know, we'd send somebody over in the middle of the night for stitches, and they'd end up getting admitted for a UTI, you know,
everyone's admitted.
and
For, yeah.
yeah, so I'd go over to the CEO the next morning. I said, "You're killing me," you know. We could be getting $600 a day on from managed care for this patient or Medicare. I said, and you're getting whacked for an inappropriate admission. So he said to me, Joe, he says, I'd rather have 40% of the DRG rate than nothing. You know, so it's like, you know, and Brad, I know things have changed over the years, but you know, maybe not so much, but a lot of hospitals really just are still about filling up beds. What do you see
Oh yeah,
that? Yeah.
I absolutely. I see that a lot. Right. You talk to the CFO of the nursing home off the record, he'll tell you, I'm very happy to take the readmission penalties. I need the DRG payments to cover the payroll next month.
Right.
Right.
Yep.
But that's why the path to success, in my opinion, is through the physician staffs.
Mm-hmm.
Right? Because you're bypassing all the business people. If you get
Right.
your physician medical director have a relationship with the head of the hospitalist program, the head of the ED, guess what? They're going to do the right thing by the patient. You know, look, I'm not a clinician. I'm a business person. It does come down to dollars, but we are managing healthcare systems with people who went to medical school and nursing school and social work school because they want to take care of patients and do the right thing. So if you give them the tools and you give them the ability to do the right thing, they'll do it.
Yep.
Absolutely.
Jeremy, you asked a good question before too about what are the, I mean, you talked about the skills the nurses need, but how about in administration? Like Brad, what do people who run the nursing homes need to pay attention to more under this model? You know,
You have to get the contracts with the payers. You know, it's complicated. Um, if you're running a single facility, it's really difficult to get the attention of the payers. If you're running a multi-facility system, you have more of an opportunity. But you just have to lean forward into the situation and have the discussions. Otherwise, nobody's going to give you the payment, right?
yeah.
Plain and simple.
Is there an opportunity for multiple unrelated, but in, you know, geographically located nursing homes to kind of bind together with an ACO?
So that is a great question. I was the chairman of the board of the nursing home owned by the town of Greenwich, Connecticut, where I live for 3 years. I'm still on the board. And that nursing home had and still has some significant challenges that we've been working through. But the long-term challenge is running an individual nursing home and having some sort of an association of nursing homes, some sort of an IPA that allows you to negotiate it as a group, right? Thinking about clinically integrated networks with your hospital partners, not just having somebody try to get the referral before your competitor gets the referral, but really thinking about the clinical programs that that the hospital needs in order to discharge patients sooner and sicker. Yeah.
Yeah.
That's the future.
That is
no
a great
question.
opportunity because we do have, you know, up in central New York, we have, even though we might be geographically an hour away from each other, we may all have the same medical director because it's upstate New York. And, you know, how many are there really out there? So I think that I could see that as being a really, if you could, you know, kind of band together in an IPA and be able to manage some of these contracts, I could see some real benefit without having to cross that border of affiliation. And Joe, you and I both know how painful affiliation is in New York State.
Oh my gosh. Painful. It's an understatement.
New York State is not the best environment to actually try to get anything approved regulatory wise. So, but that is a topic for a different episode. Brad, are there any technologies? I know you talked about that really cool AI tapping the doctor on the shoulder, saying who should be seen. Are the, are those some of the technologies we should be investing in to bring this forward?
So I think that will happen. I know that PCC has almost 90% of all the nursing homes in the United States on their electronic medical record. So I know from conversations with their C-suite that they're making investments in that regard. Sure, that's coming. A lot of what technology will do is to help the payers garner higher reimbursement for those same patients. The rules behind these ACO and ISNP programs are incredibly complex, and being able to get the risk adjustment that increases their payments, which therefore increases the amount of money in the pool to be shared. That's a thing. But my experience has been to actually be successful, to be a leader uh, in the clinical and financial metrics that represent success. It's just thinking creatively and getting back to the basics, right? We all think in in terms of what the system will pay for, but if you uh, decouple that and you say, okay, in my community, how can I treat and place more effectively? Get diagnostics done more quickly, so you're not transferring patients out to an ED because you can't get certain basic diagnostics done in a timely fashion, right? Once you've got a partner who can pay for whatever you agree with them that they will pay for, you can do those things. So I don't think it's, interestingly, despite my personal involvement with two significant technology success stories in long-term care, I don't think that's the solution here today. I think the solution for the long-term care facilities, the role of the facility is not to get the RAF score up, the risk adjustment factor score up that causes Medicare to pay more. The role of the facility is to drive outcomes. And the way you do that is by having an involved, engaged medical director, having a director of nursing who's on board, and just thinking creatively about why patients leave your building for care and how can you find ways to keep them in the building or bring them back before it's a full hospital admission and that, call it $18,000 payment for care that you could have delivered in the nursing home.
And that's amazing, Brad, because nursing homes have been around for a long, long time, and it always boils down to the nurse assessment and how involved the nurse is and how involved your medical director is, regardless of what is newest type of regulatory game that Medicare is playing with us or Medicaid. The way to take care of people ultimately boils down to the leadership of the medical director, the involvement of the leadership within the nursing home itself.
Absolutely. Without that leadership, people just revert to the path of least resistance, which is send the patient out. Bad for the patient, bad for the family, and bad for the healthcare system from a cost perspective.
Absolutely.
When I was a director of nursing, I learned that you do rounds, right? You can just do rounds and stop by the nurse's station and chat, or you can do rounds and pay attention to some things that you think are important. Like if you go to a unit and ask for, from the pressure ulcer report, who's at risk for skin breakdown, and you pop into that room and see just, how good is the offloading of pressure, and talk to the staff about it and raise a concern if it wasn't done appropriately. That shows them that that's important to you. And they know, lo and behold, you're not just going to come by and walk through the unit. You're actually going to look and see how they're performing. So it's what you pay attention to becomes important to people because they know they're going to get called out on it.
Absolutely. Yep.
When I was a nursing home administrator and I would do survey prep, some of my initial survey prep was always wheelchair pedals. And I would have meetings. I'd talk to people about wheelchair. You got to have your wheelchair pedals on. You can't just ask the resident to lift their feet up. Have the wheelchair pedals on.
Yeah.
And then
it's simple.
I'd say call people out on it. Call people out. And and call me out, because if you see me pushing someone with no wheelchair pedals, I might be doing it because I forgot, but I'm probably doing it to see who's going to call me out first. You're going to hopefully call out your friends.
I'll tell you a quick anecdote about simple solutions, right? Something that I've done many, many, many times over the years when trying to break the back of a culture of sending out. And in facilities with multiple physicians, right? So downstate New York, there's a lot more of that than upstate. But okay, new rule. Anytime you want to send a patient out, whether it's the attending physician or a floor nurse, you must contact the medical director 24/7. Now, that system is incredibly effective.
Yep.
Incredibly effective. All right. So early on, and the medical director in question, whose name I will not mention, but Joe knows, early on, I did that. And I get a phone call a couple of days later from the medical director of this 500 plus bed nursing home. And he said to me, "Doctor, fill in the blank, he keeps calling me in the middle of the night." And I said, "Yes, well, we're reducing our rate of hospitalization." He said, "That's great. Fire him immediately. I don't want him calling me in the middle of the night." Okay. You have to have a medical director who's willing to engage and be that leader and change behaviors.
That's incredible. That is amazing. All right, Brad, if we wanted to connect with you and learn more about value-based care and ACOs, where could we do that?
So happy to converse with anybody who's interested. You can use my personal email address, which is Brad Markowitz, BradMarkowitz @gmail.com.
Great. Outstanding. Thanks for coming on to the podcast. We really enjoyed this conversation. I think it was a lot of fun and it was very informative.
Likewise. Thank you.
Thanks, Brad.
All right. Thanks for listening to the Leaders Abstract. These episodes are available on Spotify, Apple Podcasts, and YouTube. Feel free to reach out to me on LinkedIn, Dr. Jeremy Rutter, or my intrepid co-host, Mr. Joe Tomaino, also on LinkedIn. I've been your host, and this has been the Leaders Abstract.